Good morning, good afternoon, everyone. Welcome back to our third day of and also the final day of Southeast Asia and the Western Pacific bi-regional FETP COVID-19 online conference. I hope you all enjoying the today's meeting. And today we will have one oral presentation session and one keynote speech. Now I would like to hand over to Dr. Martin to moderate the oral presentation section. Dr. Martin.
Thank you, Dr. Wan Chin. Welcome, everybody. My name is Martin Kirk.
Martin, you're on mute. Martin, could you unmute, please?
Thank you very much, Carl. Hi, my name's Martin Kirk. I am an epidemiologist and I'm a professor at the Australian National University. I'm also the acting chair of the advisory board of TEFINET. It's a great pleasure for me to moderate this session today. I would ask that everyone mute themselves if they're not presenting, so that we don't get background noise. We have 4 presenters in this session today. There will be 10 minutes for presenters to go through their slides and present their material, and then we'll have 10 minutes of questions which people can use the chat. So without any further ado, we will start with the first presentation, which is Ngoc An Hoang Thi from the Master of Applied Epidemiology program in Australia, and she's based in Vietnam as an ASEAN fellow. She's going to be presenting to us on investigating COVID-19 transmission in a tertiary hospital in Hanoi, Vietnam, using social network analysis. Thank you very much, Ngoc An.
Thank you. So can I start?
You can start.
Okay. So hello everyone, my name is Hoang Thi Ngoc An. I'm a scholar of Master of Applied Epidemiology at Australian National University and Vietnam National Institute of Hygiene and Epidemiology. Today I'm sharing to you a presentation entitled Investigating COVID-19 Transmissions in a Tertiary Hospital in Hanoi, Vietnam, using social network analysis. Next. Here is the outline of these presentations. We will go through 4 sections, from background and aim, methods, results, and conclusions. Next. The first of COVID-19 confirmed case in Vietnam was in January. However, we experienced the first case in a healthcare facility 2 months later. It appeared in the largest hospital in the northern Vietnam, with the capacity is more than 1,400 beds and over 4,000 staff. Quickly after the confirmations, the National Steering Committee of COVID-19 Preventions incorporated with the hospital to investigate the disease sources to control this situation. Next. In this project, we aim to study the transmission pattern during this outbreak with the support of social network analysis. Next. We take data from 3 sources. Case interviews to know about the exposure, the connections among other cases, and the list of close contacts. We check PCR testing from testing management system of the from the National Institute of Hygiene and Epidemiology. And we got data of movement monitoring, the mobile checking, and video surveillance to fill the contact tracing list. Next. So to support for studying disease transmissions, we use social network analysis. For people who are not familiar with this term, in the couple of next slides, I will show you some basic information about what network is and why we want to study network. However, this is a complex term and hard to explain all in some slides. I suggest some additional information of social network analysis for those who would like to learn more about it. Basically, a network is a set of objects which we call nodes that have some relationship between each others, which we call edges. For this project, a node is presenting for a confirmed case, and an edge indicates the relationship during the infection time among cases. Next. The objective of social network analysis is to find important cases in a network. However, there is many ways to think about the word importance. Each metric of network will decipher the word importance in a different way. In this study, we use three most common metrics of the network: the degree centrality, between need centrality, and chronic centrality. In the next slide, I will show you some basic information of these metrics. I performed the analysis using R with the iGraph and CNAR package. Next. So one way to define the important nodes is case who have a lot of friends. So the degree centrality makes the assumption that important nodes have many connections. Okay, what have a centrality of 1 if it connects to every single node in the network, and a centrality of 0 if it connects to no node in the network. For example, case number 27 have a degree centrality of 10 because she contacts with 10 other cases during their infection time. Another way of measuring importance is nodes who have very close to other nodes in the network. And the assumption here is that important nodes are going to be very short distance away from all other cases in the network. And the other way of thinking about importance, what we say that important nodes are nodes who have tend to connect other nodes in the network. So we could imagine measuring the importance by the fraction of shortest path that pass through a particular node, which we call between need centrality. Next. In there, we are going to cover what we did to control this outbreak in Vietnam. We did a blanket and general testing, more than 7,000 tests among nearly 2,000 people inside the hospital. Because this hospital have a large number of patients and caregiver visits and examinations, it's reasonable to concern about the local transmission in community at that time. The board of hospital director decided to extract the list of outpatients who visit the hospital in March. Then they send them to CDC in 49 provinces for tracing. More than 26,000 people were tested. Next. We confirmed 45 positive cases related to this outbreak. Most of them were in middle age and female. Ancillary support staff made up to nearly 60% of total cases, while the rest of profession is minor. The important is that 23% of total number of ancillary support staff inside the hospital were positive for SARS-CoV-2. The hospital issued many interventions to control the spreading. Right away after the date of index case confirmations, all staff and people inside her department were tested for SARS-CoV-2, and her department was stopped examination for outpatients. And 12 days after the date of first case detection, all people in the hospital were tested for SARS-CoV-2, and the hospital was locked down for 21 days. Next. Here's the outline of the hospital. The red border indicates the regions where the case were confirmed, and the number inside the red circle is to depict how many cases were placed in this area. For example, in the supermarket and canteen area, 26 cases were confirmed. You can see in the bottom of the graph, the first index case were in tropical disease center in a nurse. Within nearly 2 weeks later, it expanded to other 6 different departments. As you can see in here, the infected areas in North Crater is scattered around the hospital. Next. There are some graphs of each metric that I mentioned earlier: degree centrality, between need centrality, and chronic centrality. In here, the ancillary support staff are presented in the red color, while the dark blue color for other cases. Among 45 cases, a total of 67 connections were detected, and the crucial case of transmission network was case number 27. She is ancillary support staff who linked to the most other case in the network. In other words, if we remove her, it's called the network fracture and break up into different components. Among 10 most important cases selected by each network metric, the transmission dynamics cluster in 15 cases. 60% of them were ancillary support staff, while others were caregivers and patients. Next. In Vietnam, ancillary support staff have a role of distributing food and drink on own wards, so they have a high frequency of moving around the hospital. However, they were not well equipped with the knowledge and skills needed to prevent infection. To understand why and how ancillary support staff were popular in this outbreak, we visit their accommodations and interview their movement inside the hospital. They live in, you can see in here, they live in a small enclosed place. Only 15 to 20 square meter may contain 10 to 12 people inside. They do almost casual living activity together. However, they were overlooked in the outbreak response, which is mainly focusing on the clinical staff, patients, and caregivers at that time. Next. Our findings provide evidence to Vietnam Ministry of Health and the board of other health facilities to prevent disease in healthcare settings. We highlight that the disease does not focus on particular groups of people. It is important to prevent disease for all people inside the hospital. We also reveal the potential of social network analysis to understand the SARS-CoV-2 infection patterns in the hospital and similar contexts. According to our evidence, we recommend to monitor all employees with high-frequency movements for SARS-CoV-2 infection, regardless of their position and professions. Thank you. Next. So there are some people and organizations I would like to send a special thanks to contribute for these presentations. Thank you.
Thank you very much, Anne. That was excellent. We're all clapping. So the floor is open for questions. I've got some questions coming through on the Google Sheet. So Nyok, and one question is, how did you identify the connections between cases? Did you interview them?
Oh, okay. Can you get back to slide number? Just a moment. Can I get back to slide number 25? Number 5, sorry. Okay. As you can see in here, the data source is come from 3 sources. Firstly is the case interviews. We interview the confirmed case about the exposure and the workplace connections. Interview them 14-day history travel, whether they contact with other case, confirmed case, or potential exposure source. And we also take the data from hospital surveillance system, the movement monitoring, mobile checking, and video surveillance. The investigator was separated into many teams by activities, contact tracing, testing, movement monitoring, so on and so forth. I'm not a member of movement monitoring, so I don't have much information about it. However, according to my understanding, after the confirmations, the case were interviewed by a standard form for the history for 14 days from the date of symptom onset or date of confirmations, whichever came first. Then the patients were asked to use their mobile phone number for mobile checking to support the close contact investigations. They can miss some information due to the recall bias. If they refuse the checking, they have to commit with the information fulfilled. Most of our case were post their COVID-19 status on social media, the Facebook and Zalo account to inform other people. So many people who have close contact to the confirmed case will sell presentations at healthcare facility before the health staff approach. So it is excellent in Vietnam. You don't have much human resources to investigate the close contact list.
Thank you, Nyok. And a couple of other questions. One person has asked what social network platform was used.
Okay, so the social network support serve for the main function to find the important case in the network. So for this project, with the informations of case interview and epidemiological investigations, we highlight the important ancillary support staff to infection transmissions. According to the statistical analysis, I show that I will use the chronic centrality, between centrality, and degree centrality. It is the three most basic metrics for the social network analysis. So the network in here concrete the evidence of important to prevent disease for all people inside the hospital, regardless of their position and profession.
I think it was actually, the question was more about what package, but I think one of your colleagues has answered. That's okay. So a couple of other questions though. We've got quite a few questions, which is good. So one is, who employed the ancillary staff, and can you explain why there's more females than men?
Okay. So can I get back to slide 13? Okay. So in Vietnam, ancillary support staff have a role of distributing food and drink on own work, and especially in no. Can I get back to the slide 13? Slide 13, please.
1-3. So Taiwan, just one, yeah, one more slide, yeah.
Okay. So the ancillary support staff have a role of distributing food and drink on own work in Vietnam. I think in Australia, they don't have ancillary support staff in the hospital, right? So most of them were in female. The ancillary support staff, the characteristic of ancillary support staff were female and in the middle age. So they have a high frequency of moving around the hospital to distributing the food and the boiled water to around the hospital. So it is a question, right?
Yeah.
Is the answer of the question? Yeah.
So another question is, could the cases in the hospital be due to sources from outside of the hospital, so infected in the community?
Yes, we have 3 outside secondary case outside the hospital, but all of them were only connect with the confirmed case inside the hospital. They don't have a travel history or contact with other potential source outside the disease, outside the hospital. So, however, we failed to find the initial source of hospital transmissions because we did not perform the genome sequencing to all confirmed case at that time, because it's very beginning of outbreak in Vietnam, the COVID-19 outbreak in Vietnam. Yeah.
Okay. And I have a question for you, Ngoc An. You've said that social network analysis is important, and I agree that it is, but can you do it quickly enough in an outbreak like this to be able to make decisions for public health?
Oh, thank you for your question. It's a very interesting question. So it is our concern about how to implement quickly the social network analysis to provide evidence for to preventing the disease in hospital. So it is actually in Vietnam, it's not popular to use social network analysis to investigate the disease. So in this outbreak, it is a lesson known. Actually, the social network analysis performed along with the outbreak, but it's mostly done after the outbreak get controlled. So although it's helpful, it takes the lesson learned for us to implement quickly for the next outbreak.
Yeah, good. Great work. Well, thank you very much for your presentation. There are a couple more questions in the chat, so I would encourage you to respond to those directly. We're going to move on to the next presentation, which is Dr. Yang Li from Taiwan, FETP, So Dr. Lee is going to present on the epidemiological investigation of the first locally acquired case of coronavirus disease 2019, identified by influenza surveillance, Taiwan, February 2020. Thank you very much. Dr. Lee. You there, Dr. Lee?
Okay, we unmute our voice. Yes.
Okay.
Oh, do you hear me? Okay.
Yeah, we can hear you. Thank you.
Okay. Good morning and good afternoon, everyone. Next, COVID-19 and influenza share similar clinical presentations. Taiwan CDC has conducted an enhanced surveillance program for COVID-19 since February 12. Severe complicated influenza is a notifiable disease in Taiwan. It's defined as influenza-like illness patients who die or need intensive care due to severe complications. These patients are reported to the existing influenza surveillance system and tested for influenza virus. Severe complicated influenza patients with negative flu test were retrospectively tested for SARS-CoV-2. During January 31st and February 15th, a total of 113 specimens were tested and one was tested positive for SARS-CoV-2, who was the index patient. Next. Based on preliminary information, the index was a 62-year-old male and had underlying conditions of hypertension, diabetes, and hepatitis B. He was reported as severe complicated influenza on February 3rd and was tested negative for influenza on February 5th. Then he was tested positive for SARS-CoV-2 on February 5th and died of severe pneumonia and sepsis on the same day. However, the source of infection, activities, and history of contact of the index was still unknown. Therefore, Taiwan FETP was called for investigation on February 15th. Next. Our objectives are to identify activities and clinical course of the index, trace close contacts of COVID-19 cases, and prevent virus transmission. Next. We conducted a case investigation to identify contacts of COVID-19 cases. COVID-19 cases are defined as persons who were tested positive for SARS-CoV-2 by RT-PCR. We interviewed his family members, healthcare workers to identify activities and clinical course of the index. In laboratory investigation, the source swab was tested for SARS-CoV-2 by RT-PCR. In environmental investigation, we reviewed infection control practices and medical records in the hospital and identified aerosol generating procedures during the hospitalization. We also checked the surveillance videos in the clinic and hospitals to evaluate the risk of infection. Next. Close contacts of COVID-19 cases are divided as persons who had contact with cases with 2 meters for longer than 15 minutes, while cases were symptomatic, or healthcare workers who provided medical care or performed HGP without appropriate personal protective equipment. And close contacts were tested for SARS-CoV-2 based on the risk of infection and quarantined for 14 days after last exposure and retested if they became symptomatic. Non-close contacts are defined as persons who contact with cases over 2 meters or less than 15 minutes, or healthcare workers who provide medical care or performed HGP with appropriate PPE. Non-close contacts have conducted self-health management for 14 days and were tested if they developed symptoms. Next. The index was a taxi driver and had no travel history in the past year. Family members saw the index coughed several times during a family lunch on January 27. Therefore, he visited 2 pharmacies and 1 clinic for medical treatment on January 28, February 1st, and 3rd, respectively. Next. We identified 11 close contacts of the index among family members. As figures show, 10 had eaten lunch with and talked to the index. Another one was his ex-wife, who had a physical contact with the index in ICU during hospital visit. 4 family members are tested positive for SARS-CoV-2, including case 2, case 3, case 4, and case 5. All 4 secondary cases had eaten lunch with or talking to the index without a mask and within 2 meters. Because his cough got worse and developed shortness of breath, respiratory failure, he was admitted to the outpatient of a hospital and transmitted to the emergency room on February 3rd. Then he was isolated in an active pressure isolation room and ventilated with a closed suction system in an ICU on February 4th and died on February 5th. Next. We found that airborne precaution was implemented during February 3rd to 13th, and surgical mask was used instead of N95 masks when caring for the patient during February 14th to 15th. Therefore, healthcare workers who wore surgical masks in ICU are all listed as close contact of the index. Next. So we identified 28 close contacts among healthcare workers in the hospital, including 1 doctor, 21 nurses, and 3 assistants, and 3 respiratory therapists. All of them were tested for SARS-CoV-2. However, none tested positive. Next. In summary, 39 close contacts of the index were identified, including 11 family members and 28 healthcare workers. And we also identified 297 non-close contacts, including workers in healthcare settings, in clinics, pharmacies, taxi company, restaurant, and passengers. None of symptomatic non-close contacts were tested positive. In total, 4 family close contacts tested positive, and the family attack rate was 36%. Next. In total, we identified 84 close contacts and 177 non-close contacts of 4 secondary cases in different settings, including family, neighbors, clinics, co-workers, restaurants, and funeral service. None of them tested positive for SARS-CoV-2. Next. Our investigation has limitations. We are unable to identify the source of infection because more than 14 days have passed since the onset of the index, and family members are not sure about exact activities and the onset date of the index. Due to record bias of family members, some contacts may be missed and not be traced. Next. In conclusion, we identify a COVID-19 patient by existing influenza surveillance. Second, the index caused COVID-19 transmission within the family by eating meals or talking without protection of the mask. Third, no healthcare workers were infected, which indicates the importance of wearing PPE and early isolation of undiagnosed patients with pneumonia. Finally, we didn't find further transmission of the virus from this family cluster. Next. To prevent outbreaks, we recommend enhancing COVID-19 surveillance by testing influenza-like illness patients with pneumonia for SARS-CoV-2. So, Taiwan CDC continues to detect COVID-19 through influenza surveillance. Second, family close contacts of COVID-19 patients should be traced, tested, and quarantined as early as possible. Third, healthcare workers should follow infection control practices and use appropriate PPE when caring for patients with pneumonia of unknown etiology. Next. Thank you.
Thank you very much, Dr. Lee. The floor is now open for questions. I might start with one. You have recommended that severe influenza surveillance helps identify COVID-19 cases. I'm wondering whether you have seen cases that have been co-infected with influenza and SARS-CoV-2.
Do you mean the co-infection by influenza and SARS-CoV-2?
Yeah.
Oh, the index case, may I have page?
Because this patient was negative, but I'm wondering if you found that they were positive, would you stop looking for SARS-CoV-2, or is it on the respiratory panels?
Oh. In our investigation, we didn't see any co-infection of influenza and SARS-CoV-2. Yeah.
Okay, thank you. So a couple of questions coming through. So one question from Taran Bhagatna is, what was the difference in secondary attack rate for close and non-close contacts? How did that influence your contact tracing strategy?
Oh, yes. There are differences in secondary attack rate for close and non-close contacts. For close contacts, we only tested positive case among close contacts, and the total close contacts of this investigation is 123, and then 4 of them were tested positive. However, in non-close contacts, we identified 497 close contacts, and 0 were tested. None of them tested positive.
So you did test them, the non-close contacts?
Symptomatic non-close contacts, we will test them.
Okay, great. Another question to you is, how do you define adequate or inadequate personal protective equipment?
May I have page 25? As this table shows, the appropriate PPE was defined as in outpatient and emergency room, healthcare workers should wear surgical mask. And for persons who transfer patients, they need to wear a N95 mask, gloves, and a gown. In ICU, healthcare workers need to wear a N95 mask, gloves, and a fluid-resistant gown, and a face mask, and a hair cover.
Thank you. Are they your current infection control recommendations?
Do you mean the healthcare worker in hospital follow the infection control? Yes, yeah. They follow the infection control measures, but in last few days, because of the X-ray result of the index improvement, so part of the healthcare workers use surgical mask instead of N95 masks in less than 2 days during February 14 to 15.
Mm-hmm. Okay, question from Alden Henderson. How did the household contact differ from the hospital contact?
Sorry, I didn't follow your question. Could you repeat it again?
Yes, I can. So the question is, what is the difference between the contacts in the home compared to the contacts in the healthcare setting? What do you think was the difference that might explain the different attack rate?
Actually, the family close contacts, including household contacts and non-household close contacts of his family members, and in hospital contacts, most of them are healthcare workers, such as healthcare workers, including doctors, nurses, radiologists, respiratory therapists, laboratory technician, and administrative staff, clinic staff, patient transport staff, and a driver. And in family contacts, we listed in our application is the who have hospital visit. That is his ex-wife and participant in a family lunch on January 27.
Okay, thank you. A question from Abdulel Manouf. What measures were taken for non-close contacts? Did you find significant importance in tracing non-close contacts?
In our investigation, we track non-close contacts and only tested if they develop symptoms. I think although we are not identified any positive cases in our investigation, I think it should be traced either to explain the importance of close contacts and non-close contacts in contact tracing.
So were non-close contacts put in quarantine?
Non-close contacts are put in self-health management, and they will traced by local health bureau. They will trace their symptoms every day.
But not quarantine, so they just self-monitoring their health.
Yeah, they are educated to keep social distancing and keep the face, keep wearing mask when they go outside.
And is that still your current advice in Taiwan for non-close contacts?
Oh, yes.
Good. You are doing very well. So I think that's really all of the questions. Most of the questions that have been put up, you have addressed them all. It was an excellent presentation. Really great to go back to the first cases in the outbreak and see how it started. So I'd just really like to congratulate you on a really fantastic presentation. So thank you very much, Dr. Lee.
Thank you.
Okay, so our next presenter in this session is Dr. Tan Siok Hong from EIP Malaysia. Dr. Hong will be presenting on a review of 5 years between 2014-2018 of tuberculosis mortality in Kedah, Malaysia 2020. How far are we in achieving the Sustainable Development Goal target? Thank you very much, Dr. Hong. You may start, Dr. Hong.
Hello. A very good morning and afternoon to everyone. Today, I shall be presenting a review of 5 years tuberculosis mortality in Kedah, Malaysia. How far are we in achieving the Sustainable Development Goal target? Next. Tuberculosis is one of the top 10 causes of death globally and the leading cause of death due to a single infectious agent. In 2019, an estimated 1.4 million people died from tuberculosis, with 10 million new TB cases diagnosed. Probability of developing the disease is much higher among people living with HIV and people affected by risk factors such as undernutrition, diabetes, smoking, and alcohol consumption. Next. Ending the global TB epidemic has the SDG target of 90% reduction in TB deaths by 2030 compared to 2015, aiming for a 35% reduction by 2020. Next. This review is focused on Kedah, a state in northern Malaysia with a total population of 2.2 million. It has a multi-ethnic society with good access to public healthcare facilities. Next. In 2019, the TB incidence rate globally was 130 per 100,000 population and mortality rate was 16 per 100,000 population. Malaysia is classified as a country with intermediate burden of tuberculosis. However, although the mortality rate globally had reduced, Malaysia's TB mortality rate had increased from 5.6 to 6.8 per 100,000 population. Next. TB mortality rate in Kedah State, shown by the blue line, was initially lower than the TB mortality rate in Malaysia, shown by the orange line, up to 2013, but has since overtaken the national mortality rate since 2014. Next. The objective of my review is firstly to study the trend of TB mortality in Kedah State to see whether it is in alignment with the SDG goal of 90% reduction in TB deaths by 2030. Secondly, to identify the risk factors associated with TB mortality. And thirdly, to recommend measures to reduce TB mortality. Next. This was a cross-sectional study. Data from 2014 to 2018 was collected from the MyTB system, which is a Ministry of Health TB surveillance registry, as well as from TB mortality reports. Next. Mortality rates and case fatality rates were calculated following WHO definitions. All TB cases ending up in death were included in the analysis. Next. The following risk factors, which included socio-demographic and comorbidity factors, were studied. Logistic regression analysis was performed, comparing TB death group with a live and successful treatment group. Next. And these are the results. When we compare TB mortality in Kedah to the SDG target, number of deaths initially showed a decline, but has increased away from target since 2018. Next. Percentage difference between actual number of deaths and SDG target had also increased to 41.5% in 2019. Next. All-cause mortality rate, shown by the blue line, decreased to 6.7 per 100,000 population in 2017, but has increased to 8.5 per 100,000 population in 2018. All-cause mortality rate, excluding HIV, follows a similar pattern, while the case fatality rate, shown by the grey line, is between 11 to 15%. Next. Out of a total 862 deaths, 39% were directly due to TB, while 58.6% were indirect or non-TB death. A vast majority, 90.5%, were newly diagnosed cases. Next. 68.9% of deaths occurred during the intensive phase of treatment, while 31.1% occurred during the maintenance phase. According to days of treatment, 41.9% of deaths occurred in the first 2 weeks, while 13.7% occurred within 2 to 4 weeks. Next. Although PTB smear positive contributed 70.7% of total deaths, case fatality rate did not differ much between the different types of TB. All were around 12 to 14%. Approximately half of the PTB deaths presented with moderate chest X-ray changes, while 13.8% were already advanced. Next. Cases who presented with advanced chest X-ray changes had a much higher CFR at 35.9%, followed by those with moderate changes. Next. CFR increases with age, with those aged 65 years and above having the highest CFR at 27.3%. Next. Males contributed 74.7% of deaths and have a higher CFR compared to females. Next. Overall, 98.4% of deaths occurred in Malaysians. Malays contributed 81.7% of deaths. However, the case fatality rate did not differ significantly by ethnicity. Next. Rural residents contributed 66.1% of deaths and have a higher CFR compared to urban residents. Next. Cases with no permanent income contributed 73% of deaths and have a higher CFR than those with permanent income. Next. In addition, we looked at the case fatality rates by comorbidities. Bearing in mind that one case may have more than one comorbidity, the percentage of TB deaths who were HIV positive was 13%, diabetic 32.8%, and smokers 39.4% respectively. Cases with HIV had the highest CFR at 36.5%. Smokers initially had a higher CFR compared to diabetics, but from 2016 to 2018, diabetics had a higher CFR at 17.2% versus smokers 13.2%. Next. From our multiple logistic regression analysis, we found that the significant risk factors for all-cause TB mortality were underlying diabetes, HIV positive, and having moderate or advanced chest X-ray changes at presentation. Next. Other risk factors were elderly, age 65 years or older, male gender, and having no permanent income. Location of residence and type of TB were initially found to be significant on univariate analysis, but became insignificant when adjusted for in multivariate analysis. Next. So from the findings, Kedah is not achieving the SDG target of reduction in TB deaths as all-cause mortality had increased in 2018. One of the possible reasons is due to cases presenting at an ill and late stage, as we saw that among those with pulmonary TB, 64.6% presented with moderate to advanced chest X-ray changes. Next. Mortality occurring within the first 14 days was 14.9%, whereby some of the mortality may have been reversible if anti-TB therapy had been started earlier. WHO recommends diagnosis within 2 to 3 weeks of symptoms initiation. Next. Most early deaths with TB-HIV co-infection are due to TB itself, emphasizing the importance of starting isoniazid prophylaxis in HIV patients early. The finding that the TB case fatality rate in Kedah among diabetics had overtaken smokers since 2016 is worrying, as the state has a high burden of diabetes, with 1 in every 4 persons being diabetic. Next. So these are some of our recommendations. First, enhance screening strategies for early detection among vulnerable groups, focusing on the elderly in rural areas and for those with comorbidities, especially those with HIV and uncontrolled diabetes. Secondly, implement measures to address the issues on delay in seeking treatment by increasing the public and healthcare providers' awareness on TB and conducting further study to identify the factors leading to delay in seeking care among patients. Next. In conclusion, Kedah is not on track to achieve the SDG target of 90% reduction in TB deaths by 2030. Cases who were elderly, male with no permanent income, diabetic, HIV positive, and presenting with moderate to advanced chest X-ray changes were more likely to die. Recommendations to reduce TB mortality include enhancing screening strategies and addressing the factors contributing to delay in diagnosis and treatment. Next. These are some of my references. Next slide, please. I would like to acknowledge the following people who made this study and presentation possible. Next. And with that, I thank you.
Thank you very much, Dr. Hong. That was an excellent presentation. The floor is now open for questions. There is a question in the chat which is, what are the different causes of indirect or non-TB deaths associated with that you present?
Okay. Some of the causes of indirect death include secondary infection. So cause of death given as septicemic shock, for example, and severe pneumonia, but not directly due to tuberculosis. So these are some of the examples.
Okay, great. A question from Sushil Chavan. As per your presentation, smoker is a comorbid condition along with HIV and TB. Can you quote any reference for that?
In the WHO global report on TB, smoking is one of the risk factors besides HIV, undernutrition, and diabetes. So it is, there are studies which show that smoking is a risk factor.
Okay, great. One question from me. I notice that people without an income have a very strong risk factor for mortality with TB, yet you didn't make any recommendations about screening people without an income or who were poor. So interested in your comments on that.
Okay. So for those without any permanent income, these included the elderly who are retired from work, those who are unemployed, and also some who were substance abusers because they are usually unemployed as well. So in the recommendations, screening for the elderly is recommended. And of course, for those substance abusers, they are also prone to HIV infection. And we definitely recommend, it is compulsory for HIV patients to be screened for TB.
Okay, great. A question from Taran Bhatnagar. What was the proportion of transfer out and missing cases that were excluded from the analysis? Could that influence the identification of risk factors for TB mortality?
Okay, give me some time to open my data set. It is not a very high percentage. Is it possible for me to get back on this? I will type it in the chat box because I need to open my data. Sorry about that. It's a low percentage. I think about less than 10%.
A question from Tom Weiser. Is there any recommended screening for TB for people with diabetes?
Oh, yes. In Malaysia, being diabetic is actually one of the high-risk groups which we highly recommend for TB screening, especially those with uncontrolled diabetes with a poor HbA1c or poor random blood glucose. So it is already one of the strategies in our Malaysian screening program for a high-risk group for TB.
Okay, great. A question from Alden Henderson. How representative is your study population to everyone who has to? Are there groups who were underrepresented in your study?
Because in Malaysia, TB is a disease which is mandatory to be notified. So if the person seeks medical attention, and is diagnosed to have TB, then definitely it will be picked up by our national mandatory notification system. And in Kedah State, which is where my study is located, there is good access to public healthcare facilities, because we have we have 9 hospitals, we have 60 health clinics and 200 over community clinics. So issue of accessibility should not be an issue.
Okay, great. And another question from Masum Bilha from the Bangladesh FETP. What is the current TB screening strategy in the area?
So the current screening strategy is to screen high-risk groups, for example, close contacts to TB patients, and also HIV positive patients, those who are diabetic, especially those with uncontrolled diabetes, the elderly, and also prisoners. So these are the strategies which we are using currently.
Okay, great. There's a few more questions in the chat. I think we've got time for one more question. So I will take a question from Taran, which is, what could be the reasons for men being at higher risk for TB mortality? And how did you identify the confounding factors in order to adjust the odds ratio in multiple logistic regression? What was your modeling strategy?
Okay. I think because males, there are more smokers among males compared to females. And as you can see, 30% of the TB patients are smokers. So that could account for the higher risk in males. Also, again, there are more males tend to be substance abusers compared to females. So that is another contributing factor. As for how I adjusted in the multiple logistic regression, firstly, I did the single logistic regression using all the risk factors that was listed. And for those which were significant on simple logistic regression, I put it into the multiple logistic regression. And so that is how I got the significant risk factors.
Great, that is really fantastic. So I think we will call that presentation to a close. If you can answer those other questions in the chat, that would be really great. Really fantastic presentation, and thank you very much.
Sure, thank you very much.
Great. It is a bit strange having these presentations and no clapping afterwards, but I'm sure you're all clapping where you are. So our final presentation in this proffered paper session is Ratcharaporn Papwaditsil from the International FETP in Thailand. She's going to be presenting to us on an investigation of healthcare-associated measles infection in a regional hospital, Phuket Province, Thailand, July to October 2019. This happened last year, pre-COVID. So we're hearing about some non-COVID work, which is excellent. So thank you very much. You may start.
Yeah. Good morning and good afternoon, everyone. I'm Ratcharaporn Papwaditsil from FETP Thailand. Today, I would like to present an investigation of healthcare-associated measles infection in a tertiary hospital, Phuket Province, Thailand, June to October 2019. Next. Introduction. Measles typically presents with fever, cough, coryza, conjunctivitis, and Koplik spots. Rash may appear 3 to 5 days after symptoms begin. The virus is transmitted by direct contact, droplets, or airborne spread. The incubation period usually is 10 to 14 days. At present, Thailand's EPI program has provided a first dose of measles containing vaccine to children at 9 months old and second dose at 2.5 years old. Next. About healthcare-associated infection, it is the infection detected within 48 hours of hospital admission in patients that had previous contact with healthcare service within 1 year. About in measles, because of measles severity, patients often seek care in healthcare settings, posing a high risk of transmission to other patients and healthcare personnel. Next. Background, on 15th August 2019, we were notified that there was a cluster of suspected healthcare-associated measles infection in a tertiary hospital in Phuket province in July 2019. So the investigation was conducted. Next. Objectives: to confirm the diagnosis of the outbreak, to describe epidemiological characteristics of the outbreak, to determine factors related to the spreading and identify source of infection, to provide appropriate recommendations and control measures. Next. Method: we review situation of measles and vaccine coverage in Phuket province and perform active case finding by reviewing medical records and interviewing patients, caretakers, and healthcare personnel. Next. Case definition. Suspected case was anyone presenting with fever, rash, with at least one of the following signs symptoms: cough, coryza, conjunctivitis, or Koplik spots, and having history of work or visit the tertiary hospital 7 to 21 days before the onset. Probable case was suspected case who had history of contact with a confirmed case. Confirmed case was suspected or probable case who had positive measles IgM and or positive PCR for measles. Next. Laboratory investigation. We send serum IgM or throat swab PCR for measles. We analyze location linkage by social network analysis. Environmental study was done by behavioral survey and interviewed healthcare personnel, patients, and caretakers. Next. Here's come for the results. The left graph shows number of the cases in Phuket was high since the end of 2018 and gradually increased from the beginning of 2019. The right graph shows MCV coverage did not reach the target. Next. There were totally 31 cases that met case definition. Male to female was 1.2 to 1. Inpatients to outpatients was 1.4 to 1. The right pie chart shows most of the cases were pediatric patients. 19% were healthcare personnel. Next. The upper bar chart shows age group under 9 months old was the highest proportion. The lower graph shows the most complication was gastroenteritis, followed by pneumonia. The table shows patients who were under 9 months old were mostly affected by complications. Next. For symptoms and signs, most patients had fever, rash, coryza, and cough. Next. Here is the epidemic curve. Most of cases were confirmed. The onset of the first case was on 5th July. The number of cases was peaked in early August. We was notified on 15th August due to uncontrolled outbreak. Field investigation was conducted after that. No more cases since 14 September. Next. The first case was an unvaccinated 9-year-old Myanmar boy. His onset was on 5th July. He went to the hospital on 8th. At ER, he was diagnosed as viral pneumonia and viral exanthem. He went to pediatric OPD for chest X-ray, where met case 2 and 3. At pediatric ward, where case 4 and 5 were admitted before, he was nebulized. On 9th July, the diagnosis was changed to suspected measles. Then he was isolated. Laboratory results confirmed that he was measles. Next. This is social network analysis. We can visualize that pediatric OPD and pediatric ward were the places that most of the cases had epidemiological linkage. Next. Laboratory results, 5 cases were positive for measles PCR with DH genotype. For genome sequencing, 100% match of all 5 cases. 70% of 30 cases were positive for measles IgM. Next. Environmental study start from ER. There was no isolation room, no screening system for fever with rash, pediatric OPD. There was no screening desk, no standard isolation room. Next. Move to pediatric ward. It was divided to general ward and private rooms. In the outbreak situation, the private rooms were adapted to be the isolation room. All 16 pediatric inpatients were admitted here. We found the majority of cases were delayed, diagnosed, and isolated. Next. Discussion. The outbreak was the healthcare-associated infection with measles caused by the A genotype. Delayed diagnosis and isolation contributed to the transmission of the outbreak. Corresponding to previous studies, delayed diagnosis or isolation played a major role of disease transmission, resulting to the outbreak. Next. From social network analysis, the pediatric OPD and the pediatric ward were the places that many cases share a social connection. Pediatric OPD was among high-risk areas of transmission due to no appropriate isolation room and no screening point, causing delayed case detection and isolation. Next. Pre-vaccinated infants were the highest proportion and tends to have higher rate of complications and mortality. Seroprotective rate in children under 1 year old in Thailand had only 26.5%. Next. Recommendations for the tertiary hospital should set up screening system for measles at the frontline units, should strengthen infection control system in the hospital, should mop up or catch up MCV to healthcare personnel and unvaccinated patients. For Phuket Provincial Health Office, should conduct MCV catch up campaign among high-risk population in Phuket province. Next. Conclusion. This outbreak was the healthcare-associated measles infection, mainly affected pre-vaccinated children. Delayed diagnosis, delayed isolation, and poor hospital infection control contributed to the spread of the disease. Surveillance of measles and isolation precautions were recommended to prevent future outbreaks in healthcare settings. Next. That's all for my presentation today. Thank you.
Thank you very much, Dr. Papajitsil. Questions, the floor is open for questions now. One question I have to start off is, you mentioned there was a recommendation to the Phuket province to conduct catch-up campaigns for measles-containing vaccines.
Yes.
Do you know if that has happened? Because we're very concerned about what has happened to vaccination currently with COVID-19. So we'd be interested to know, has that happened?
Yes, in Phuket province, it is the island in Thailand, and there are many migrants or foreign laborers working in Phuket province. And in some community, for example, in the Myanmar migrants community, that community that communities are the vulnerable people living there. So for Phuket province, for the Phuket Provincial Health Office should go into that community to find the problems that the people who live in that community have the health problem. For example, no vaccine or no immunization in the people who live in that community, and in some people that have poor hygiene or poor education, that the Phuket Provincial Health Office should pay attention to that community.
Thank you. So there's a few questions have come through. One from Mengyu Chen. Were all the cases unvaccinated? Were there any breakthrough infections?
Yes. There was one case that she was 40 years old, and she, from the history, from the investigation, she got 2 MMR vaccine already, but she got measles in this outbreak. But there is some limitation, for example, about the information bias, because she just only tell us about the vaccine history that she got, and we think about the secondary immune failure from the vaccine also, but no evidence to support it.
Okay, thank you. A question from Tom Weiser. What is the case notification to the government for measles? It seems you were notified long after the beginning of the outbreak. So can you tell us about how cases are notified to government?
Oh, yes. Actually, the hospital staff, the epidemiologists in the tertiary hospital, that observed that there was a cluster of pediatric inpatient with measles. So they notified to DDC. They notify us that they suspected is that related to the healthcare associated infection or not. And then they notify us.
Yeah. So is it mandatory? It's mandatory by law to report measles cases to the government?
No, just only a cluster in there was no the number, the exact number that how many cases that should be notified. But if the outbreak happens in the closed places, for example, in prison or in school or in in hospital setting, they should notify to the central government.
Okay, so it's clusters. So a question from Masum Billah from Bangladesh FETP. Did you visit the catchment community of the hospital? Were there any outbreaks in the community at the same time?
Yes, there was a small cluster of measles outbreak in the Myanmar school, but just only few cases in that school. Yes, it happened before outbreak in the hospital.
Okay, that's great. A question from Taran. What was the secondary attack rate by pediatric general private ward? How would you explain the difference?
Could you please go to slide number 13? From this epidemic curve, we can see, if we can imagine the wave of the graph, we can see the peak was in early August and a peak again in mid-August. That can show like the secondary wave and the tertiary wave of the outbreak. So actually, we cannot identify the secondary case exactly, but we can assume that the secondary infection that can spread in between the end of July to the early of August. But most of cases were the children under 9 months old in the pediatric ward.
Okay, great. So a question from Dr. Jaffrin from FETP Bangladesh. Why are the pre-vaccinated children having more measles? Is there any other study to see whether there is any problem with vaccination?
In pre-vaccinated children are the children under 9 months old that they totally not get the vaccine.
Yeah.
Absolutely. And this age group tends to have like a maternal antibody from the placenta and transmit and go through the children. But in many studies show that the remaining maternal antibody in this group is disappear maybe from 3 to 4 months after birth. So this group is higher susceptibility to measles infection, of course.
Okay, thank you. Another question here with a comment. Nice presentation. Could you tell us something about the sensitivity status of measles surveillance in Phuket province? So how sensitive is the surveillance?
Sensitivity of status, measles surveillance.
Yeah.
In this study, we did not calculate. We did not perform to do the sensitivity status of the measles surveillance.
Can you give us any comments about how sensitive you think it is? Is it detecting most of the cases of measles, or you think there are problems there?
Yes, the sensitivity that about the measles surveillance in Phuket is quite high. But from you can see from the review in the slide number 9, please. Please go to the slide number 9, please. Yes. Yeah, the left bar graph shows the review situation of measles cases in Phuket province. You can see the blue line is the 5-year median. 5-year median of the number of cases in Phuket province. You can see it's just a few cases in 5-year median that I have reviewed. So the sensitivity in the past 5 years is not quite high, but I think after 2019, the sensitivity is higher.
Well, certainly able to detect cases. Another question from Suganya Barani. If pre-vaccinated children are affected, do we have to recommend an earlier vaccination schedule to avoid infection?
Yes, in Thailand, especially in the 3 southernmost provinces in Thailand, we recommend that for the provider should give early vaccination to the children that can give since 8 months old, especially in the endemic area of measles. So in this situation, I think if the situation in community get higher infection rate, the recommendation should change from 9 months old to 6 months old, also like at 3 southernmost of Thailand.
Okay, there's a couple more questions in the chat. I'm going to ask you one final question, then if you can go into the chat and answer the others. So the final question from Tom Weiser is, how many of the healthcare personnel were unvaccinated? Is it required?
I have no data about the unvaccinated healthcare personnel, but in this outbreak, we recommended for all healthcare personnel should be provided for the measles containing vaccine to all healthcare personnel, especially who working in the front line units. For example, OPD or ER, something like that.
Okay, that is great. Thank you very much, Dr. Papwetitil. Really great presentation. In fact, all 4 presentations were excellent. They covered a range of different topics. We saw social networking twice, which is really good. So the front and the end. I think that really challenging questions that all presenters were able to answer well. So I just want to thank all of our presenters today, and I congratulate you on doing such great work in the field and presenting here today. So I'm going to hand over to Dr. Wan Chin, as this is the end of this proffered paper session. So thank you very much, everyone.
Thank you, Dr. Martin, and congratulations to all presenters today. Now we are going to have a break for 40 minutes. And please enjoy your coffee, tea, or lunch by yourself at your program site. So in the closing, we will give a word to outstanding presentation. Please, for the audience online and all presenters, please stay with us until the last minute. Thank you.
Thank you.
Good afternoon, everyone. Welcome back to our next session. So that's a keynote speech in this afternoon. Right now, I would like to hand over to our moderator, Professor Yiren Cai, for moderate the keynote speech. Dr. Professor, please.
Yes. Good afternoon, everyone. My name is Elun Cai from the Department of Veterinary Medicine, National Pingtung University of Science and Technology in Taiwan. I'm going to serve as a moderator for the session of this meeting. I think it's very good to have this session because in these 3 days of meeting, we heard or share the information about the diseases in humans. But in these days, concern about the One Health, the relationship between animals and human beings, and also the environment. So I think cover the session about the animals is very important. So now I would like to introduce Professor Zhenxuan Liu. He's a adjunct professor and former dean in Graduate Institute of Molecular and Comparative Pathology and Department of Veterinary Medicine in the National Taiwan University. In this session, he's going to talk about SARS-CoV-2 in animals. So that's welcome Professor Liu for this speaking.
Okay, thanks, Professor Cai, for that introduction. I'm Zhenxuan Liu, Professor of Veterinary Pathology from the School of Veterinary Medicine, National Taiwan University. And today I'm going to present the so-called SARS-CoV-2 infection in animals. But the title is COVID-19 in animals because the COVID-19 is the disease name in human beings. But in animals, we don't name it. So we call the COVID SARS-CoV-2. From the title, frequently several questions we will ask. Do animals have their own coronavirus? Are they able to infect a human being? This is the number one question we try to be addressed. And SARS-CoV-2 transmission, everybody knows it's mainly human to human transmission. But how about animal to human, human to animals, and animal to animal? We are really concerned about this. And next, we are talking about a little bit the status of natural and experimental infection of SARS-CoV-2 in animal. Finally, I will briefly mention the animal model for COVID-19. Okay, in recent 20 years, a lot of human beings facing the emergent or re-emergent zoonosis. That is the big challenge and highly impact. So approximately about 3/4 of the human emergence the infectious disease are caused by zoonotic pathogen. And among them, 75% emergence zoonosis is from the animal, particularly wildlife. Why? Because the two factors is one is deforestation, the other is illegal the animals and the bushmeat trade. In addition to this, the other factors like we increase the human population and increase livestock population, and rapid urbanization and climate change, and change to the agricultural system and the trade globalization. So the deforestation and the illegal bushmeat trade probably is the main factors cause a lot of the emergence disease in human being. Regarding to the wildlife, and we are concerning the wildlife, particularly in the bats. Several disease viral zoonoses from the bats. As you see it here, bats can cause through the intermediate host, like host, cause the Hendra, and through the pigs, is the Nipah, and through the civet, SARS, and camel, MERS, and probably penguin or unknown the intermediate species to cause COVID-19. But like rabies and Ebola, probably do not need the intermediate host. Talking about the coronavirus, generally speaking, and host range and the main target organs, no matter in humans or the animals, the host range including mammals, poultry, and whale or dolphin. Main target organs is GI tract and the respiratory system. I would say a lot of the collection for today's presentation, the information regarding the scientific literature, papers, veterinary group organization are contributed to this presentation. I really appreciate it, particularly in CDC, USDA, and OIE, WHO, all contributed this presentation. So now I summarize, update the coronavirus in human and animals. So here we see a lot of the disease, in particular in poultry. In the first is infectious bronchitis. This is the first coronavirus discovery in humans and animals. So veterinary, the field, has fight coronavirus almost 90 years. And poultry and turkey and dogs, we still have the respiratory and enterotic infection. And we will talk the SARS-CoV-2 later. And cats, they have the FIP, feline infectious peritonitis, feline coronavirus enteritis, and SARS-CoV-2. And pigs, there's at least six infections, including GI tract and respiratory, and as well the central nervous system. And cattle, bovine coronavirus infection, rats and mice to have murine viral hepatitis. And human, so far we have the 7 coronavirus in the human beings. In addition to that, tigers and lions and mink, particularly susceptible to the SARS-CoV-2, the infection, ferret too, and whale and dolphin has their own coronavirus, and others including horse, rabbit, ruminant, birds, non-human, primate, and bats. So a variety of the animals can be infected coronavirus, but there are few or not cross-species transmission. Okay, let's talk a little bit about the infectious bronchitis in chicken. This is kind of the first discovery of the coronavirus. This is an acute and highly contagious coronavirus in chicken. It can cause respiratory and reproductive infection. Some strains will affect the urinary system, particularly in the kidney. Okay. Fortunately, we have the live attenuated and oil inactivated vaccine to control the disease, but not 100% efficacy. So this is a clinical sign, open mouth, and this is a trachea. This is a kind of the cast, and the swelling in the kidney, and the tracheitis. And the transmission route of coronavirus infection, I will say this is a general transmission, including the human and animals. Okay, first the digestive tract, the kinds of fecal oral transmission. This is including the feces, feces, saliva, and the wastewater. Okay, SARS-CoV-2 detected in Italy, Australia, and Spain. And the respiratory tract, like the air drops, everybody knows that. And conjunctiviral in infectious bronchitis is very popular. And milk in pigs, we have the transmissible gastroenteritis in pigs, but not found in human being. Semen, PED, plasma, and vertigo, like the COVID-19. This is identified in Italy, 2 out of the 31 pregnant women. And on fetus and the placenta, we can detect the virus. And so far, we mentioned 7 types of coronavirus known to infect humans since 1960. That means the human being has fight the coronavirus since 1960, like almost 60 years, but less than 30 years than the veterinary field. The first 4 it's kind of a mild infection, like the influenza or like the cold. But since 2003, SARS and MERS and SARS-CoV-2 leads to human to form the global pandemic, still the highly impact in economic traveling and lots of the things. So we are concerning the animals and SARS-CoV-2. So this summary is from the OIE and update data. So I will list the species, types of infection. Susceptibility is called none, low, or high, and clinical signs and transmission. Okay, the first minks, everybody will know that this is used naturally. Naturally is highly susceptible. Clinical signs, yes, yes. And between the minks, but we have to pay much attention that in recently, mink is only one animal species can transmit the virus to the humans. And the second is case, is natural experimental, is high, yes, clinical sign, but between the case also can be transmitted. And tigers and feathers, this is a very high susceptible. And Egypt fruit bats and tree fruit are experimental, is high and low. And macaque, that is a kind of the non-human beings for experimental, because it's very similar to the human beings. So these are highly susceptible. Clinical signs, yes. Transmission, yes. Raccoon dogs, this is experimental, high susceptibility. And dogs can be natural and experimental case, but very low really low susceptible. And the clinical signs, no. And the transmission, no. Probably they are very viral low in their bodies. And rapid and cattle, experimental, that's very low or no clinical signs. And domestic animals, including pigs and poultry, because this is very close to the human environment. This use the experiment inoculation. They are not none or low the infection, and no clinical signs, no transmission. And so, because SARS-CoV-2 is a notable disease, should be reported to OIE. So right now, in OIE documents, dogs, cats, tigers, lions, and minks can be naturally infection of SARS-CoV-2. Okay, let's talk a little bit about the clinical diagnosis of animals infected with SARS-CoV-2. I will say this is a very limited knowledge, very limited because we don't have the many cases. Okay, so from the limited knowledge, incubation period is 2 to 2 weeks. Range means probably 5 days. And current evidence, I mean the clinical signs, just like coughing, sneezing, respiratory distress, nasal discharge, and ocular discharge, vomiting, diarrhea, fever, and lethargy. And many of them are symptomatic of the infection, just like a human being. And we talk about the mink. Mink right now in many countries, including the United States, Netherlands, they have thousands of mink died of SARS-CoV-2. You see the lung growth region are diffuse consolidation and dark red. And histopathology, we see very similar to the human pathology, such as diffuse alveolar damage, we call DAD, formation of hyaline membrane, formation of syncytial cells, and with type 2 pneumocyte proliferation. It's very similar. And recent news, we know about the mink and SARS. Minks are the only one animals known to have passed the coronavirus to humans. 214 human associated cases documented in WHO, except to the initial spillover even from an unknown species. Right now, 6 countries have the cases outbreak in minks. SARS-CoV-2 variant, right now we are concerned called cluster 5. That's a mutation. So to avoiding the mutation to spread to human beings, there are culling of the millions of minks performed to prevent further changes for the virus's spread. And everybody knows the laboratory diagnosis of SARS-CoV-2 in human beings. Very similar, we use the similar tools to detect the SARS-CoV-2 in animals, including how to take the samples, the procedures, agent identification, such as RT-PCR, RT-LAMP, virus isolation, virus genome sequencing, and detection of the immune system, immune response, particularly use ELISA antibody test or virus neutralization test, because we try to find the intermediate host or reservoir in the animals of this kind of the virus. We should use know the diagnostic tool to find intermediate host or reservoir. This is it's kind of not practical to use animal to inoculate the virus because too many animal species. So the OIE encourage the member country to use serological test to trace the infected animals. So serological test to SARS-CoV-2 intoxicant. First in China, they test 1,053 cases, all are negative. Also use the RT-PCR to confirm the result. And second, China use 102 sample from the case and find 15 cases is ELISA positive, and among them 11 had neutralization antibody. The other study from Italy, large scale, and total of 870 companion animals, that means dogs and cats. They find the serological positive 3.5% dogs and 3.9% cats. That means cats and dogs can be infected with SARS-CoV-2. And recently, we studied the paper, serologic survey SARS-CoV-2 for experimental domestic, companion, and wild animal. This paper excludes the intermediate host of 35 different species of animals. So all negative results of the ELISA antibody. This is from the almost 2,000 serum sample from the 35 animal species, including domestic animals, poultry, experimental and companion animals, and wildlife. So they need to do it again, dogs, cats, mink, tigers, and all are negative. Okay, in addition to serological test, several months ago, they have the paper studied use the computer to analysis the by comparative and the structural analysis of S2. They try to find the intermediate host. They try to classify 5 categories like a very high susceptible is a human and non-human being, and high and medium like the case. This computer speculation is not really reflect the natural condition. There's a lot of the factors can be. That means not 100% match. Okay, and just 2 days ago, this is a very nice the paper. They use cell culture to predict what kinds of animals are susceptible. I think this is very practical. They use airway epithelial cell, so-called AEC culture, for a variety of animal species to assess their susceptibility to SARS-CoV-2. They use in monkey, cat, ferret, dog, rabbit, pig, cattle, goat, llama, camel, and 2 bats. But just only replicate efficiently in monkey and cat. That's a pretty match to the nature of the infection. And let's talk about the animal model for the human COVID-19, sorry about that. So these cats and kids, how a feline disease may help us unravel the COVID-19 associated with pediatric hyperinflammatory syndrome, because I know the children are very few cases, them adults infected with SARS-CoV-2. But here, the two disease, one is from the cat, we call the feline infectious peritonitis, we call the FEP. This is a very popular and very severe feline disease in cats. The first, most of the young animal or children. Second, start with GI tract. Third, the children will show the ascites and pleural effusion. It's very similar to the feline infectious peritonitis. And also infections, monocyte and macrophages. And in cats, they cause the granulomatous vasculitis. And this is sometimes like a Kawasaki syndrome. And also overexpression of inflammatory cytokine, particularly in tumor necrosis factor alpha, interleukin 1 beta, and interleukin 6. And also lymphopenia possibly caused by mediated apoptosis. This is a similar situation occurring in the FEP. So, and finally, remdesivir is successfully being used the treatment of the FEP. So this is show the FEP, feline infectious peritonitis, and this is from the ferret, so-called ferret coronavirus associated disease. The two diseases is very similar, the disease mechanism, and shows here's the intestine, and here's a loss of the granuloma associated, accompanying with the intestinal wall. So I think this is probably pretty good the model of the COVID-19 infections in children. Okay, listen, the very interesting thing is that because as you know, dogs are very smart and have the very good smelling. So in many countries like Helsinki and Germany, in United Kingdom, they use the dog as to sniff with SARS-CoV-2 the patient. This is in Helsinki. They put the dogs to sniff the COVID-19 the patients. Okay, that's a summary of the current study of the SARS-CoV-2 and animals. Number one, SARS-CoV-2 is mainly human-to-human transmission. Number two, naturally infection of SARS-CoV-2 in dogs, cats, tigers, lions, and other animals are really rare. So based on the limited information, risk of animals mentioned above, spreading COVID-19 or SARS-CoV-2 to people is considered to be low. SARS-CoV-2, but finally, SARS-CoV-2 can jump back and forth between the minks and humans. This is a summary from the current study of SARS-CoV-2. And precautionary measures, everybody knows that if people infected with SARS-CoV-2 should avoid close contact with the companion animals. And handling and caring the animals, basic hygiene measures should be always implemented. Okay, we talk about One Health. That is mentioned in early this century. But the concept 100 years ago, as in German, the Dr. Rudolf Virchow, everybody knows that he is famous for the pathology, for the fathers of modern pathology. And he said, between animals and human medicine, there is no dividing line, nor should there be. The objective is different, but experience obtained constitute the basis of all medicine. See, he talk about this very useful the message. So right now, we are very popular, say one medicine, one word, and one health. And so-called one health, that means physicians and veterinarians who share their expertise can improve the medicine and health in all the species. Okay, this is the end of today's presentation. Thank you. And any questions are welcome.
Thank you very much, Dr. Liu. It's a very good presentation. I think all of us were updated from you about the recent articles and information about the COVID related information. And before we have other question, I think I have one question for you. And based on recent information, we know there's some infection in minks, and based on the molecular evidence, is like maybe it's related to another clade, like clade 5. And do you have any information about how these minks get infected firstly, and what's the mutation possibly happened in this group? And is it possible to like make the molecular mutate or hybrid in that group and create another virus to get serious infection to humans? Do you have any information about that?
Okay, this is a good question from the professor's side. As we know, still right now, we still have limited information about the mink SARS-CoV-2. But they speculate first from the human with the COVID-19, and they work in the mink farm. They infected the virus to the mink. And after several months, the SARS-CoV-2 in the mink body, they mutated. So right now they have 5 different variants in Denmark published. And after mutation, they transmitted from the mink to human. They have the genetic evidence to show that is from the mink. The virus transmitted from the mink to the human. So this is just published 2 days ago from the Science. So right now, in the world, they are concerning the mutation really initiate the second wave of the global pandemic, or most important thing is because right now the vaccine is developing. Is that what, it will affect the vaccine development. That means this probably the vaccine is against the transitional, the COVID-19, SARS-CoV-2. But how about the mutate? So these are the people's concern about that.
Thank you for your answers. And I continue with this question, since we don't have much information on the animal side. So I think from the news, we know that this mink in Denmark maybe need to be sacrificed for human beings, but right now they stopped doing that. So in your opinion, from this evidence and the information so far we have, how will you suggest for this situation? And also concerned about the animal welfare.
Okay, that's the big and good questions. Regarding the mink industry, before the outbreak of SARS-CoV-2, a lot of the animal rights and animal welfare supporters, they ask the main countries such as Denmark, Netherlands, Spain, and United States, and Poland, because they are the main country to produce the mink for fur. And right now, they find the very good excuse because the mutation occurring in the mink. We should stop the industry. So based on the government policy and avoiding the mutation to spread the human being, so they have to take the precautionary measures to covering all the, I think this is a big disaster, but they have to do that. Okay, so as far as I know, in Denmark, they claim 2024 to stop the older mink from the industry. So that is for the precautionary measurements. So let's wait and more the scientific evidence and see what can we do the next step. Thank you.
And here there's a mention below Bangladesh give a question for you, and they want to ask, do you think this animal infection with SARS-CoV-2 are sporadic, or they have any relation with human infection, like higher density of human infection could transmit it to animal?
Okay, thank you. This is a good question. Regarding to the transmission between the human and animals or animals. So from the scientific evidence, because as you know, global the pandemic of SARS-CoV-2 almost 1 year, I mean 11 months. So we feel almost like the huge human population infected with, but we find less, like 100 natural infection. So that means the animals, including dogs and cats, and even the lions, is not the susceptible species, I mean, compared to the human being. But it means, why? Because the mink industry, they rest pretty close. That is in the crowded environment. So that's easily to get infected. But the dogs and cats is companion animals that individualized by the human being. So it's number one, human is a very close contact, and the mink farm is crowded condition. So easily, if the people get infected with SARS-CoV-2, then transmit the mink. And we have to learn if the virus successful infect the human or animal, they have three criteria. Number one, you have to enough the virus variant. Second, the host should have the adequate cells receptor, such SARS, MERS, such SARS, COVID-19, they use S2 as the receptor, but the MERS, they use DPP4. But in dogs and cats, they use APN. Okay. Number three, your immune system should be absent or invalidated. So the virus should through the 3 doors can get into the body. So probably like the dogs and cats, they don't have enough the S2. Like right now, the human compare. Why the Asian population and the European country, the infected people is not compared, disappropriate, because they think probably S2 in European or the United States, the people, maybe the S2, the quality may be less than the Asian people. Okay, maybe this is, and how about, I think this is a very good question. We can search the S2 the receptor. That's easy because we have a lot of the forensic cases. You can do the forensic pathologists that they do lots of the necropsy cases from the children neonatal, and also adult. So we can use the immunocytochemistry to detect the H2 in lung tissue. That can solve some problem. Why some people are very susceptible to the SARS-CoV-2 infection, some are not. I think this is a very good the study. Thank you.
Thank you very much for your detailed explanation for this answer. And I also have another question. Is there any documented evidence of human to animal transmission of SARS-CoV-2? Is there any documented information so far?
Yes, we have the scientific paper. I think just published 2 days ago or something. Just the 2 papers just mentioned from the scientific evidence to show the evidence that's the mink, that's the kind of reverse the zoonosis. That means from the mink infected back to the human being. That's definitely. And so I will mention that. So mink is only one species to transmit the SARS-CoV-2 from mink to human. Dogs, cats, lion, that's not.
Okay, so I think last question, just echo what I asked. How was your opinion about culling of animals, and is it necessary for public health measure?
Well, this is a really big question. It depends on what viewpoints the culling policy. From animal rights and animal welfare, the group, they 100% support the policy. Okay, because and based on because the human rule the world, from the human the viewpoint, I personally supported the culling policy, but you have to base on the scientific information. As you know, every day, every week, tons of the information regarding the COVID, SARS-CoV-2, they are coming out. You cannot easily digest all the papers. So, well, and I think different people has a different opinion, but I personally, based on the precautionary measure and animal-human rights, animal rights and animal welfare, I supported the policy. Thank you.
Thank you very much. Sorry to need you to, to tell us your opinion. And I think, thank you very much for your presentation and your clear answer for our questions. So I think we're gonna stop here for this presentation. Thank you.
All right, we have come to the end of our 3-day conference, and thank everybody for sticking up, staying with us over the last 3 days. So before we go to our closing, I would like to give the opportunity and give the time to the Director General of the Taiwan Centers for Disease Control, Dr. Zhou, to announce the awards for the conference. Dr. Zhou, please.
Thank you, Angela. And I will say we had planned to give out 2 awards from outstanding presentations. However, the score was very, very close, and we had a tie. So there are 2 second place awards. The first one goes to Nokan Hong from the Master of Applied Epidemiology Program of Australia for the presentation titled Investigating COVID-19 Transmission in a Tertiary Hospital in Hanoi, Vietnam, using social network analysis. Congratulations, Dr. Hong. And the second place is Tan Xiao Hong from the Epidemic Intelligence Program of Malaysia for the presentation titled Review of 5 years to 2014 to 2018 tuberculosis mortality in Kedah, Malaysia. How far are we in achieving the Sustainable Development Goal targets? Congratulations. And finally, the first place winner is Harlin Kwao from the Master of Applied Epidemiology Program of Australia for the presentation titled In-Flight Transmission of SARS-CoV-2 During a Long-Haul Flight, Results from an Outbreak Investigation in Vietnam and Application for Future Air Travel. Congratulations. Congratulations to all the presenters for a job well done and to our prize winners.
The Minister, Taiwan.
Thank you, Dr. Zhou. Right, so we are finally at the very end. Can I have Dr. Martin Kirk to give us some final thoughts, please? Martin.
Thank you very much, Angela. Well, it's a great privilege to be involved in this conference. I have been involved with the TEPINET network for around about 10 years, and I've loved it. It has been a great opportunity. I'm sad that people haven't got the opportunity to join together in Taipei this week, but I'm extremely glad with the quality of presentations I've seen, the engagement of the residents, the questions from the resident advisor. It's been really fantastic. I think, this is a conference at a very unusual time as well. It's one of the first virtual conferences we've had on field epidemiology. There's never been a time quite like this for field epidemiology trainees. Who would have thought a year ago that we would have had travel bans around the world, that we'd be doing contact tracing on thousands of cases, that we'd be running quarantine stations, isolating people who are infected, providing epidemiological reports, conducting investigations. So, and I think we've seen that during these 3 days. We've also seen that important work of communicable diseases and other non-communicable diseases is still going on, and it still matters immensely. One of the things that's happened in this time of COVID-19 in Australia is we've run out of epidemiologists. I don't know whether in the country, but in Australia, we've had a lot of clinicians have to go in, leave the hospital posting and go into the Ministry of Health and assist with running the response. So we've had infectious disease doctors, family physicians, academics, all sorts of people are in the public health response. And they have a need for the skills that you're learning. So I think as field epidemiology trainees, it's a critical time for you. I think it's a wonderful time to be an FETP fellow. It's terrible to have the suffering and misery of a disease like COVID-19 affecting our populations, but it's going to be continuing in its importance next year when we have changes in mobility restrictions. There's going to be continuing need for surveillance and outbreak investigation. And when we roll out vaccines, there'll be need to estimate vaccine effectiveness and adverse events and a whole lot of other things. So I just encourage you to get involved and jump in. And we've seen that here. I just want to finish up by congratulating all the speakers that I heard. They were all absolutely fantastic. I'd like to congratulate the resident advisors on all of the programs who've done such a wonderful job coaching their fellows and helping them and working tirelessly behind the scenes. One important organisation that has done a lot of work here, which is behind the scenes, is Safety Net. And they're incredibly important for the two regions joined here in Southeast Asia and also Western Pacific, and we really want to thank Conchi and Conky for all of their work. Of course, the Taiwan CDC, we really congratulate you for your bravery in putting on a conference like this in a time of COVID, and we're looking forward to joining in Taiwan when we can. So, you know, the team in Taipei has been amazing. They have really managed this process incredibly well, particularly Wan Chin and Angela. And I really want to express our gratitude from Tefinet to the Director of the CDC and other Ministry of Health staff. And then I'd like to thank the organising committee, who's also been really fantastic as part of this as well. So really big congratulations to the Taiwan FETP for putting on this conference. Thank you.
Thank you, Martin. And some final thoughts from Dr. Mohakar in India. Dr. Mohakar, to you.
I hope you can hear me.
Yes, we can.
Yes. Good morning and good evening and greetings from India. And we are in the closing of this conference, and it is really my privilege to say a few words in the closing ceremony. First, let me talk about the nature of conference. It was an online conference, and everybody wanted to come to Taiwan to have a face-to-face conference. But because of COVID restrictions, this was not possible. But despite these restrictions, we had a wonderful 3-day conference wherein we had very, very good scientific discussions. And the credit for organizing this conference goes to conference organizer. And I want to congratulate the organizer, especially Taiwan Ministry of Health, Taiwan FETP, and SafetyNet for organizing this beautiful conference. Day one, we had country presentations, and they described the situation of COVID in their countries. And they also talked about the role of FETPs, the FETP trainees and FETP graduates in the response. And it was really incredible to listen to this presentation. And one thing which has come up very clearly is the importance of strong FETPs in the country in managing any emergencies, be it infectious disease emergency or any public health emergency. So the country needs a very strong FETPs, and I congratulate all the FETPs for putting a strong response to COVID. We also had a very good panel discussion on day one, where the experts provided a perspective to the pandemic from the point of view of an infectious disease specialist, of an economist, and an ethicist. And it was really a learning experience for all of us. So I again want to congratulate the conference organizers for this. The last 2 days, we saw 12 FETP presentations, and want to thank and congratulate all the presenters for making beautiful presentations, and special thanks to the award winners, the 3 award winners which were just now announced. I must mention here that the selection of abstracts was a very competitive process, and because of a short timeline, we had to, or short time that was available for the online conference, we had to only select 12 abstracts with 2 abstracts per country. So again, the scientific committee did a very good job. They selected 12 best abstracts. And again, I want to thank the conference or the scientific committee of this conference for selecting the abstracts and also carefully putting the agenda of this conference. Conky informed me that more than 600 participants registered for this workshop, and more than 80 participants registered for the pre-conference workshop. So I am very sure that for all the participants, it was a very good learning experience. The last point from my side, as Martin mentioned, COVID is going to be with us for quite some time, and we need to be prepared we need to continue to respond to this emergency. And the current strategy for response revolved around testing, around tracing, around quarantine, and around isolation. And as Martin mentioned, we will be having another tool for responding to COVID, that is vaccine. We hope that vaccine will be available early next year. And I feel that the programs, the FETPs, need to work with the ministries, the respective ministries of health, especially to identify priority groups for vaccination, because vaccine is not going to be available for the entire country. So we need to identify the priority groups. The programs also need to identify strategies to vaccinate these priority groups, and more importantly, document the entire process of vaccination, including the AEFIs, that is the adverse event following immunization. And this will not only be useful for the country, but also neighboring countries, or countries in the region, to learn from each other's experience. So I once again thank the conference organizers and congratulate all the award winners, all the presenters and participants for their interaction. So thank you very much.
Thank you, Dr. Murka. And finally, I will once again invite Dr. Zhou Zhihao, the Director for Taiwan Centers for Disease Control, to give us some final thoughts.
Thank you. Dr. Barheka, Professor Kurt, and Dr. Lim Kizong, distinguished guests, ladies and gentlemen. On behalf of Taiwan Centers for Disease Control, I would like to thank you all for your participation and contribution to this important conference. And we are especially grateful to so many experts as well as trainees and graduates of FETP to share important public health information. As we have learned different COVID-19 responses from each other, it is now time that we put into practice what we have discussed. Taiwan will host the 10th TAFINET Bi-Regional Scientific Conference in Taipei from May 31st to June 4th, 2021. We can continue the discussion we have started here at next year's conference. Thank you again for your participation, and I look forward to seeing you all in Taiwan next year. Thank you.
Thank you, Dr. Zhou. And that concludes our conference, and I hope to see everybody in Taipei next year. Thank you. And we should have a post-conference survey that's up on YouTube. And so please help us and fill out our post-conference survey. And we really would like to see you in person soon. Thank you.